Assalamu alaikum warahmatullahi wabarakatuh. Ramadan Mubarak and very good evening to all the viewers who have come online for today evening's webinar entitled Pediatric Endocrinology webinar organized by Dubai Pediatric Club in affiliation with Vitabiotics New Country Healthcare. Myself Tawfiq Ali, Country Business Manager of Vitabiotics. And to proceed with today's session, I would like to invite Dr. Sohrab Tomarai, the President of Dubai Pediatric Club and Senior Specialist Pediatrician at NMC Specialty Hospital, to take over the session. Dr. Sohrab, please.
Thank you very much, Mr. Tawfiq. Good evening, ladies and gentlemen. Ramadan Kareem. I would like to take this permission to share my slides. Is it okay, Mr. Tawfiq?
Yes, doctor, you can go to the first slide.
Well,
no, it's not projecting, doctor.
Not coming?
No.
Is it okay now? Is it okay?
Yes, doctor.
Okay. Well, once again, good evening, ladies and gentlemen. On behalf of my colleagues and the organizing committee and members of Dubai Pediatric Club, I would like to welcome all viewers from Dubai, UAE, GCC countries, and other countries, especially UK and India. Well, today's webinar is Pediatric Endocrinology, and we have eminent speaker and panelists. In a short while, I'll be introducing them to you. Two of them, Dr. Asma and Dr. Nandu, well known in UAE. Dr. Ima, first time she's presenting in DPC. In a short while, I'll be introducing her. Well, beautiful Dubai as usual. Sheikh Zayed Road in the background. Burj Khalifa, the tallest building in the world. I would like to invite those viewers who have not seen Dubai to come and see this beautiful city. Members of Dubai Pediatric Club in the second and fifth annual conferences, on behalf of all of them, I would like to once again welcome all the viewers. Well, members of the organizing committee, Dr. Rajinder Joshi, Dr. Kalpana Sen Gupta, Dr. Diari Muhammad, Dr. Amir Toleimat, Dr. Ayman Jundi, Dr. Rafia Overa, Dr. Srinivas Pandari, Dr. Leila Bahri, and Dr. Khalid Rashid. We are missing Dr. Bushra. She is joining us from Canada. We would like to welcome her also. Well, today, topics on pediatric endocrinology. Our speaker is Dr. Emma Webb, consultant pediatric endocrinologist from Norfolk and Norwich University, UK. She will be talking about metabolic bone diseases in children and adolescents. We are having distinguished panelists, all of you know them. Dr. Asma Jaseb Binjab, consultant pediatric endocrinologist at Sheikh Khalifa Medical City, Ajman, and Dr. Nandu Talange, consultant pediatric endocrinologist at Jalila Children's Hospital, Dubai. Well, we have two moderators, Dr. Rajendra Joshi, senior most consultant pediatrician at Prime Group, Prime Hospital. He was the past president of Dubai Pediatric Club. And we have Dr. Kalpana Sen Gupta, senior specialist pediatrician and head of Department of Pediatrics at NMC Specialty Hospital, Dubai. She is secretary of the club. They will be joining us, Dr. Joshi and Dr. Kalpana, in question and answer session after Dr. Ima completes her talk. Well, in future, on 23rd, Sunday, 23rd of May, we have a webinar all about the vaccine. Detail of that, it will be announced. And our biannual Dubai Pediatric virtual conference will be on Friday, 28 May 2021. We have eminent speakers from all over the world. There will be pediatric nephrology, pediatric rheumatology, pediatric cardiology, and pediatric radiology talk. We will have 3 panels also. Well, here, this is the 7th consecutive year that Mr. Tawfiq Ali, the country business manager of Vitabiotech, is sponsoring DPC. He has been seen here being felicitated by the founder of Dubai Pediatric Club, Dr. Led Kuhi, in the first DPC annual conference. Well, a brief, very brief, in 2 minutes, I would like to give the history of pediatric endocrinologists. You are seeing the portrait of Dr. Wilkin. Well, always Hippocrates, the father of medicine, we start in his name. Well, Lawson Wilkins is the father of pediatric endocrinology. Here you are seeing Dr. Meegan, a student of Dr. Wilkins, and in spring of 1950, Dr. Lawson Wilkins made a presentation at the 6th International Congress of Pediatrics in Zurich that gave birth to the new field of pediatric endocrinology. Well, this is an interesting photo. This is in front of Harriet Lane. All of us, we are having Harriet Lane book. This is the Harriet Lane John Hopkins Clinic. The first endocrine clinic was formed in Harriet Lane, and this clinic, in this clinic, they were seeing the growth disorders in children, how important is growth. Today also Dr. Ima will be talking with other panelists. Well, 2 of the pioneers, Dr. Blizzard and Dr. Meegan, they were the president of Pediatric Endocrine Society for 40 years. Well known, very well known in pediatric society. And today we are having 3 eminent speakers and panelists well known here. Dr. Asma, Dr. Ima, Dr. Nandu. Dr. Asma and Dr. Nandu are very well known. Dr. Ima, for the first time she is presenting. So Dr. Ima, well, I will just briefly introduce her. She is consultant pediatric endocrinologist at the Norfolk and Norwich University Hospital, UK. Dr. Asma is a consultant pediatric endocrinologist at Sheikh Khalifa Medical City, Ajman, and Dr. Nandu is a consultant pediatric endocrinologist at Jalila Children's Hospital, Dubai. Very briefly, I would like to say a few words about Dr. Ima's profile. Dr. Ima graduated from the King's College London in 2002, having completed BSc in endocrinology during her undergraduate training. She obtained her MRC PCH in 2005 after training in general pediatrics at King College Hospital and University College Hospital, London. She worked as a research fellow in South Africa, where she conducted a large prevalence study to assess the risk of Mycobacterium tuberculosis infection and disease in the pediatric diabetic population during 2006 to 2007. She completed a PhD in 2013. She was awarded the highly prestigious Donald Patterson Prize by the Royal College of Pediatricians and Childhead UK for her work on the effect of growth hormone deficiency on neurocognition. She worked as an academic clinical lecturer at the University of Birmingham between 2014 and 2017. She moved to Norway to take up a pediatric endocrine consultant role. This is a very brief profile. She has a large CV. So with this, I end. Beautiful Dubai. You see 2 structures which are the best in the world, first in the world. Burj Al Arab, the first 7-star hotel in the world, and Burj Khalifa, the tallest building in the world. We would like to welcome all those who have not seen Dubai to come and see. Thank you very much, beautiful Dubai. With this, I end. I would like to request all viewers to write their questions. And after completion of Dr. Ima's talk, question and answer panel will start. Thank you very much. Over to Dr. Ima. Thank you. Dr. Ima, please.
Good evening, everyone. I'm just going to share my slides. Thank you for that lovely introduction. And thank you for the invitation to talk to you this evening. I know it's quite late with you. So this is, can you see my slides?
Yes, Dr. Emma.
Brilliant. So hopefully this is a useful, practical approach to bone health. I'm quite simple about how I see things. And I've also tried to include some of the really exciting new therapies that have recently or are about to come onto the scene in children's bone health. And I'm doing this with 4 cases. And I know the writing is very small in this first case, so bear with me. But this is a letter, these are letters that my pediatric orthopedic colleague sent to me. And it starts in July 2013 with a 3-year-old girl. So she comes for review together with her mum. Her mum is happy that her flat feet are improving as she gets older. Playgroup is a bit worried about her gross motor development, as she's always last when running or jumping. There are also some concerns about her speech, but I understand she's seen a speech therapist and everything was fine. According to mum, there's no other areas of concern, so no other past medical history. Mum herself said since the subdural hematoma, when she was accidentally dropped, the family have been understandably concerned about this young lady. On examination, she has a normal gait. She has bilateral flexible flat feet, age-appropriate genovalgum, and no evidence of instability at her knees, and nothing else on examination. She has blue sclera, but mum tells me she had the same and this changed as she grew. She has no signs of skin hyperelasticity or excessive bruising. So once again, I have reassured mum I can't find any sign of abnormality. The tone in her limbs is normal. I cannot find any signs of collagen disorder or neuromuscular disorder. So this isn't an unusual case seen by our orthopedic colleagues. She's now 4 years old. It's a year later, and this is another letter. So all concerns that there were previously about her development have resolved. Everyone's happy about her. Again, I can't find any abnormalities except some hyperextension at the knees and increased dorsiflexion at the ankles. We've noticed her blue sclera before, and when she was younger, she had a head injury with subdural, which was investigated extensively. She's never broken any bones. So I've discharged her from clinic, but would be more than happy to see her again if there were concerns in the future. She's now 5 years old, and she's been referred back because she's got blue sclera and issues with her left foot. She's got lots of aches and pains, particularly after she falls, and her reactions to falls is quite exaggerated, with simple falls resulting in pain that's prolonged for a few days. She still has very blue sclera. The dentist has no concerns with her teeth, but to the orthopedic consultant, they look a bit abnormal, and she's got a triangular face. So the only other thing when this girl presents at 5 years of age is that she's complained of a lot of back pain. And so very sensibly, she has a lateral radiograph of her thoracic and lumbar spine. And this is what the thoracic and lumbar spine look like. And I'm going to get you to do some work. And I don't know how this works exactly, but the team, here we go. So can you tell me, what I'd like you to do is click, you can't really still see the X-ray. So there should be a poll there, and you need to decide whether you can see any vertebral abnormalities or not. And I think you've got about 30 seconds to do that. Don't know if we've got a timer within here, but. Okay, fantastic. So that's interesting. So the majority of people think there's multiple level vertebral compression fractures. So I think there's one very obvious grade 3 vertebral compression fracture, which I've highlighted in the radiograph on the left. And personally, I think the thoracic spine is really hard to visualize. It doesn't project particularly well. But maybe that, I mean, there's lots of overlying ribs and things, which I think it makes it quite difficult, but there probably are further fractures there, but there's one that's very easy to see. And one of the challenges when we're seeing people with osteoporosis and imaging their back is having a standardized way of reporting vertebral fractures. And what you can see here is the Ganant scoring system, where you've either got a normal vertebra, which is nice and square box-like, or you've got loss of height going from grade 1 to grade 3. And we recently did a survey amongst the British pediatric bone doctors and radiographers, and found that even amongst us, there's significant variation on what we will report in terms of vertebral fracture height reduction. But what's really important from a definition point of view is there a fracture or not, and recognizing it. So this young lady, after she'd had this X-ray which showed her vertebral fracture, then went on to have a fracture of her tib fib, and then a year later of her femur. So by the time she was referred to me in Pediatric Endocrine Clinic, she'd had 3 fractures, vertebral fractures, femur, and 2 long bone fractures. And we know that in terms of her family history, which had been taken in the past, there was no one else who'd had fractures, hypermobility, deafness, or early onset osteoporosis, and her bloods were unremarkable. However, it's looking very likely that she's got some sort of osteoporosis, and her history is definitely suggestive of osteogenesis imperfecta because she's got blue sclera, and her dentition is sounding abnormal. And this is just a reminder of OI. So it can present in early life with a large anterior fontanelle. Blue sclera persist beyond infancy, so many infants will have blue sclera, and some older children, but they persist. And you can see in the picture on the right, this individual's got very dark blue sclera. It's helpful often to examine siblings and proband for hypermobility. You can get bowing of limbs, that's more common in more serious variants, and you can see on the right here abnormalities of teeth, but that's not universally present. It's a rare disease. 90% of cases are caused by mutations in collagen genes. However, there are more and more rare genetic abnormalities that also present. And I'm sure that as we do in the UK, you have access to gene panels that look at all of these genes in one test to try and identify the pathogenic mutation. So the other thing I just wanted to use this case to highlight, and I think it's really important in the whole of pediatrics, is when is osteoporosis present? Because if a child has osteoporosis, that's telling us that we need to do something from a management point of view. So we need to know when that is. So any vertebral fracture, so one or more vertebral fracture, whatever height loss that is with, is indicative of osteoporosis. If there hasn't been local disease, so that would be something like ALL or high energy trauma, so car accident. In the absence of vertebral compression fractures, the diagnosis of osteoporosis is indicated by the presence of both a clinically significant fracture history, and I'll go on to what that is, and a BMD-Z score of more than or equal to -2. However, if you have a normal bone density, that doesn't mean that there isn't increased fracture risk. And coming back to what a clinically significant fracture history is, it's one of either 2 or more long bone fractures by 10, or 3 or more long bone fractures at any age up to 19. And I think that the other thing I would say from this slide is it's not unusual for children to be referred to me with a letter saying that they've got osteoporosis because their bone density is less than 2, but they've got no other fractures. So no long bone fractures, no vertebral fractures. And that in children is not osteoporosis. Okay, so now we're moving on to the next case. This is Oliver, he's 12, and he's got Duchenne's muscular dystrophy. And just to be clear, the names are not actual children, they've been replaced. He receives regular neurology follow-up. He's been on prednisolone since 8. Initially, that was a weekly dose. He's now taking it every day. He also has cardiomyopathy, for which he takes an ACE inhibitor. And from the purpose of why he's come to my clinic, he's been referred because he's got a recent history of recent onset severe lumbar back pain following a fall. Fell from the edge of his bed onto his bottom, so not a significant injury. But unfortunately, since this injury, he's no longer ambulant. He's in a wheelchair. I just want to remind, kind of think about Duchenne's, and I'm sure that this is something that you're all very comfortable with, but it's helpful thinking about why you get bone problems, because it's different to many of the other conditions that we manage. So it's an X-linked recessive disease, which affects boys, generally picked up between 4 and 6 years of age. And the majority of cases, or the most common, is because of deletion in the dystrophin gene. If it's untreated, you get progressive muscle strength deterioration. Loss of ambulation tends to occur on average around 10 years, with children dying in early adulthood. And that's why children get given glucocorticoids, because it has been shown to have very significant benefits to these young people in clinical trials, which has been borne out on multiple different trials and with clinical experience. So glucocorticoids extend life expectancy significantly, they prolong ambulation, they improve cardiorespiratory function, and they reduce scoliosis. So fantastic to the overall health of these young people, but they don't help us when we're trying to optimize bone health. And we know that if steroids are started before 5 years of age, you get double the risk of fractures. And I just want to use the next couple of slides to think about why Duchenne's is so challenging from a bone health point of view. And this is a model that we can use in any childhood disease, but it particularly helps us when thinking about Duchenne's. So bone health comes and throughout our lives based on the size of our bones, so their physical properties. So that's why in osteogenesis imperfecta, where you've got thinner, more gracile bones, they're more prone to fracture, but also that relates to muscle force. So every time we walk, it impacts on osteocytes, you get effector signals, and you get increased bone turnover, and that impacts on bone strength. Additionally, you have modulators of your bone strength, which include puberty and nutrition. And puberty is something which is also often impacted in Duchenne's. So puberty will often be delayed. And additionally, if you take high doses of glucocorticoids, that can impact on your bone strength. And so what you get is you get this, in a healthy child on the left, you've got relationship between muscle force and bone, where you've got repeated impact on the bone, which causes bone turnover and leads to an increasing bone volume and bone cross-section. However, in your child with muscle weakness, that's not happening. The muscles aren't subjecting their force on the bone. Often these children are also less ambulant, so they're not walking around as much as their peers. And then if you think about it, we're also potentially adding in glucocorticoids, which significantly reduce bone turnover. So you end up with bones which are prone to this type of picture, which is what happened in this case. And I think if you go back to the last x-ray that I asked you how were vertebral fractures were present, and I felt there was a very clear one vertebral compression fracture. Here you can see that every vertebra has significant height reduction, and that's really what we want to avoid in these young people. So vertebral fractures are very common in Duchenne's muscular dystrophy because of the reasons I've listed, and they're probably the children that I look after, other than those with severe OI, that are most predisposed to having this multiple level vertebral compression fracture. 50% of them are symptomatic, and they tend to occur about 2 years after steroid initiation. So what you should take away from that is that 50% of children will have asymptomatic vertebral fractures, which if you can pick them up and start treatment early might prevent this horrible vertebral fracture cascade. Vertebral fractures, Nicola Crabtree published a nice paper in 2018 showing that they are less frequent on alternate day steroid doses, but we do need to then remember if we're on alternate day steroids to think about adrenal function on the other day. And we know that a single osteoporotic fracture is a major event in Duchenne's. And what I mean by that is that if you have one osteoporotic fracture, that can herald, it tells you that bone health is poor, so you've got osteoporosis. And that can often be the starting point for a kind of runaway train vertebral fracture cascade where you end up 2 or 3 years later with this picture. So this is a child, and this is from a paper by Leanne Ward, who's done a huge amount of research in young people with Duchenne's, showing that particularly after steroids are added in, so we know we've already got poor bone health because of the impact on muscle strength and bone exercise, and puberty, if that's relevant at the age that the child presents. If you then add in glucocorticoids, you can get vertebral fractures as soon as 6 months after starting them. So here you can see a child that started glucocorticoids at 8. They've got 1 fracture at 9, and then 2 at 11, and the image I showed you initially then shows you another year later. So what we need to think about is, as soon as we start glucocorticoids, these young, what should we be doing differently? So what should our clinical management look like if we can avoid, in order to avoid multiple vertebral fractures when you fall off the bed and ending up non-ambulant? So we need to be thinking about bone health monitoring to identify early signs of compromised bone health. And I'll talk about how we could do that. And then once osteoporosis has been identified, we need to try and stabilize that. And that's aimed at both reducing pain and interrupting the fracture-refracture cycle through bone-targeted therapy. And then the third thing is bone health maintenance. So preserving those clinical gains we get during stabilization through ongoing bone-targeted therapy. So doing these things step by step, what do I mean by bone health monitoring? So I do 2 different things. One is looking for vertebral fractures, because if only 50% of them are symptomatic, they're very easy to miss. And using standardized reporting methods, so you try and get consistency and you can see when progression is happening. And then and vertebral fractures can either be looked at as part of your annual DEXA, if you and that's dependent on where we work in the UK, whether the images are adequate on DEXA. It very much depends on your machine, or with a separate lateral spine radiograph. So bone density, measured using DEXA, currently, we request lumbar spine and total body. It is also possible in the adolescents who are coming to transition age to look at the hip every 12 months. And the data is very difficult to interpret under 5 years of age. And then what does the DEXA result mean? So we know that low bone density is associated with fracture risk, but I've already said it doesn't equate to osteoporosis. And we also need to remember that bone density will tend to be underestimated in smaller subjects and overestimated in larger subjects. So it's really, really important that wherever you work, you know that your DEXA scanner is set up specifically for children to give you size adjusted measurements. I'm just going to spend 2 more slides talking about that because I know that when I moved to Norwich, the scanner wasn't set up like that. And it can be something that is really easy to overlook and is very important. So this is a slide from Nicola Crabtree, who's one of the world experts in DEXA. And it's trying to show you the fact that what DEXA is measured, so it's a projectional technique and it measures aerial, not volumetric bone density. So it's a size dependent technique. So on the left, you've got a cube which is smaller than the cube on the right. And yet the cubes have got exactly the same density. Neither of them is more brittle or easier to break than the other. But the smaller cube has a smaller aerial density than the one on the right, even though the volumetric density is identical. And that's exactly the same with children. So this doesn't really matter so much for adults because adults vary less from a size point of view. But we know as pediatricians that we see children who are completely different sizes at the same age, and that this is much more exaggerated if you've got chronic illness. So it's really, really important for us to think about as pediatricians. And taking it another way, so here on the left, you've got a child who's got JIA and fragility fractures. And on the right, you've got a child with growth hormone deficiency who's completely fine from a bone point of view, no fractures, no pain. But both of them have a DEXA scan. The child on the left is younger than the child with growth hormone deficiency, and they both come out with a total body Z score which is -3, so below the normal range. However, if you adjust it for their size, then the child with growth hormone deficiency does not have an abnormal bone density, whereas the child who's having fragility fractures still has a low bone density. So it's just important to check with whoever's doing your reports that they are adjusting your DEXA scan reports for size, and you should then end up with something called BMAD as opposed to just a Z score. So just to recap, because again, this is something that I've seen doesn't always, we sometimes get our words wrong. Children don't have osteopenia. They can have low bone mineral mass or density, and that's when the Z score is less than -2. And they have osteoporosis if they either have a vertebral fracture or a low bone density plus a clinically significant fracture history. So knowing that, and this is just another point, here's another quiz to see if you're all still there and awake. So which of these 3 patients has the lowest bone density score? Again, I mean, I think you probably only need 10, 15 seconds. Okay, that's 20 seconds, so that's probably fine. So fairly equal split there. Most people thinking it was patient 3 who had the lowest bone density, which I completely can see why, because you've got multiple level vertebral compression fractures, and you can also see in the patient on the right that they've had bisphosphonates, because you can see the treatment lines. But actually it's patient 1 purely based on this x-ray that has the lowest bone density. And the point of this is just to say we can look at radiographs and they can give us clues, but actually they're not a good way of reporting bone density, because they're very subjective and not the best way of measuring it. So how should we manage these patients? So the other thing we need to do, and this is talking about any patient with osteoporosis, not just the case I was discussing, is decide who needs treatment. And when we're thinking about that, then vertebral body reshaping after fracture is a key measure of recovery. So if there is potential for spontaneous vertebral body reshaping, we don't need treatment. And a good example of this would be children with ALL, who it's not uncommon for them to have a vertebral fracture at the time of presentation, but that will get better as they grow. So if you've got excellent linear growth, vertebral bodies should be able to reshape. But there are no reports of spontaneous reshaping in Duchenne's. So if any of you see one, it would definitely be worth writing that up. So thinking about this particular case, they require osteoporosis stabilization and maintenance therapy. And at the moment, the only thing I can offer is bisphosphonates, which slow bone turnover, and are probably not the best option for kids with Duchenne's because they already have really low bone turnover. And I can do very simple things like optimizing vitamin D, which is universally low, particularly in the UK, and making sure that calcium's okay in the diet. There are some really exciting treatment options on the horizon. And the one, I'm just going to show you one slide on denosumab, which is a rank ligand antibody, which is being used in adults, particularly in malignancy. And this is quite a heavy slide, so I apologize for that, but I think I'll just try and talk through it simply. So we have factors which stimulate bone resorption, which lead osteoblasts to release rank ligand. Rank ligand then binds to osteoclasts and increased osteoclast activity. And osteoclasts, when they're active, caused increased bone resorption. So what rank ligand, denosumab does is it binds to rank ligand and it stops that activation of osteoclast activity. So then you don't get as much bone resorption. So in a way, it's sort of doing a similar thing to bisphosphonates, but it has a much shorter half-life. So you can give it, the hope is that we give it together with bisphosphonates so that denosumab could be given as a initial stabilization and bisphosphonates could then be given for maintenance treatment, but that's very much the future. And then for kids with Duchenne's, we do need to remember to think about puberty and treat them if they've got pubertal delay, because not having testosterone or estrogen around will significantly impair bone health. And like I mentioned briefly, think about glucocorticoid-induced adrenal suppression, because that's associated with significant morbidity and mortality. Okay, so moving on to the third case. So the last two cases are very much about talking about new therapies. So Daisy's got short limbs, relatively large head, born by elective cesarean section, had mild respiratory distress going to NICU. On clinical examination, she's got shortening of her limbs. She's got, which you can see, she's got frontal bossing and she's got very characteristic hands. She's got achondroplasia, which is the commonest form of skeletal dysplasia, although it's still rare. We see around 25 young people in the UK per year. Actually, about 1 in 5 children aren't recognised at birth. And most clinical features relate to increased FGFR3 signaling, and it acts on endochondral bone growth. So Daisy quickly recovered. Her genetic testing confirmed she had achondroplasia. She had a cranial ultrasound. Our physios met with her to give some advice on handling and how to use a car seat and to make sure she was safe in a car seat before she went home, so didn't develop apnea. And she had a sleep study. So would you perform, you don't need to do the mentibot.com bit, but would you perform an MRI brain and spine before sending her home? And this is a yes or no answer. You can just pop the questionnaire up. And again, I'll just... Okay, that's probably fine. Hopefully that's enough time. And the majority of you would, which would be my preference. And this isn't something that there is a right or wrong answer about, but I feel it's worth discussing. There's been a lot of publications very recently about achondroplasia, a lot of them coming out of the Evelina Hospital, led by Melita Irving and Moira Chung. And they've developed a scoring system together with the neurosurgeons at Great Ormond Street Hospital to define what we see on MRI brain and make it more systematic. But what they've shown is that even if this little baby had a normal clinical examination, 50% of newborn babies with achondroplasia will have spinal cord changes on MRI. So there is really no way of determining who is the patient on the left with a normal foramen magnum, or who is the patient on the far right who's got cord compression which needs urgent intervention by examining young people clinically. And I've had personal experience of this, and I know that Dr. Nandu has too. So my preference is very much now to perform routine screening with MRI before discharging children home, because if you do have the changes on the right and don't have intervention, that's associated with significant not only morbidity but also mortality. And the mortality is high in the first 2 years of life in young people with achondroplasia. And for the majority of us, it's not something we're managing all the time. And so I think an awareness of that is really important. And all of the complications you see in achondroplasia relate to abnormal bone formation. And I'm not going to spend a long time on this slide, but what you can see is cord compression at the foramen magnum, limb length, which leads to problems accessing normal life, because life is very much designed for people of normal stature. The bony abnormalities in the upper airway leading to obstructive sleep apnea, and in the ear to hearing problems. So it's universal to have short limbs, and historically there was a lot of leg lengthening happening, but that doesn't happen really at all in the UK at the moment. But I'm aware it's very much, it varies significantly with the country that you work within. And the things that we struggle with once children are out of the really dangerous periods, the first 2 years of life, is how we support young people functioning in a world that's not designed for them. So a lot of focus on the MDT support. And there isn't a clear consensus on the best practice for how all of these problems should currently be managed. But what we hope, both with our current management and treatment in the future, is that we can improve pain, improve people's ability to function, reduce sleep disordered breathing, and reduce bone-related complications. And I just want to talk through some of the future treatment options that are almost here, which I think is really exciting. So if we go back, so FGFR3 is the problem in these young people, and FGFR3 acts to regulate the growth plate through inhibition of other growth signals. So on the left, you've got normal signaling. So you have FGFR3 signaling is activated, and you have STAT, MAP kinase, PLCG activated, and that leads to normal bone growth. But in achondroplasia, you get overactivation of FGFRC signaling, and that leads to suspended bone growth. So really what therapies have been targeted towards is how do you either modify downstream FGFR3 signaling, and that's by targeting something called C-natriuretic peptide. And there are 3 different treatments that are being in different stages of development that work on this. And I'm just going to talk about one, which is vosoritide, because that's very close to being something that we can prescribe. Really, you know, this is quite a busy slide, so again, I'm sorry, but I think it's just important to have an awareness of vosoritide. It's based on naturally occurring CMP, which is engineered to resist degradation and increase the half-life. And when the very early studies were being done in mice, in monkeys, it was shown to increase bone growth, which seemed very promising. And subsequently, this is data from the phase 3 study. Many patients were recruited for this within the UK, and you can see that the treatment, if you kind of bear with me rather than looking at the whole slide, definitely shows an increase in the height Z score, which goes from -4.5. And in you've got a run-in on the left here. So there's 18 months of run-in data to see what the trend is. And then on the right-hand side of the slide where you can see the increase, that's on treatment. And so you can see that there's a really significant increase in height. Now, what's important to know about this is the phase 3 studies, the data which is published for is in older children. So it wasn't started in babies, and the data is not yet available in what happens if you give this from birth, which as a huge amount of growth we know happens in the first 2 years of life, would be really interesting to see. And then the other option is to have a FGFR3 decoy, which is something called Theracon. And again, this is really exciting. So this has been shown to completely correct the skull morphology when given to mice. So on the left, you've got a wild type mice. In the middle, you've got a mouse with achondroplasia. And on the right, you've got a mouse with achondroplasia treated with Theracon. And you can see that it's completely restored skull size and shape. And it's also improved the size of the foramen magnum, which is the scariest complication. So this is actually now the very near future. BioMarin we're hoping will be licensed in September 21. If I have babies who are diagnosed with achondroplasia, I refer them to Evelina, and they're still being popped onto the study. And I've seen young people who've had very significant benefits from this. Phase 3 studies are starting with Theracon in 2021. And in terms of the overall consensus of how we support and best manage these young people, and come to agreements about things like should all children have an MRI before discharge, we're working together as an international group on consensus guidelines. Have I got enough time to do the last case?
Just 5 minutes, Dr. Ima.
Okay, that's fine. So we'll go through this one quickly. It's a bit shorter. This is a 4-year-old boy with short stature, bowed leg, and couldn't walk as far as his siblings. And I think it's fairly obvious that he's got quite significant bowing. So you always start with basic things. So calcium, phosphate, ALP-phos, PTH, 25 vitamin D, and that gives a lot of information, doesn't it? I think people can get scared when they measure bone hormones, and I tend to think of bones very simply, so as bricks and mortar. And what do I mean by that? So the bricks, you can either have a problem with the bricks or you can have a problem with the mortar. And if you have a problem with the bricks, that tends to cause rickets and osteomalacia. So you could have a problem with the mineral supply, that's calcium or phosphate, so calcium or phosphate deficiency, or a problem with the mineral supplier, so vitamin D deficiency or resistance, or a lack of mineral deposition, hypophosphatasia. And I appreciate that's oversimplifying things, but I find it helpful. And then, or you could have a problem with the mortar, which would be something such as osteogenesis imperfecta. So this child had a low alkaline phosphatase. So you'd first check that you haven't got sample contamination, that it's a true sample. Exclude other common causes of low ALP, so chronic illness, low copper zinc. You can also measure other hormones in the alkaline phosphatase pathway. The only one that's really available at the moment is urinary PEA. And look for other symptoms of hypophosphatasia. So you'd expect an elevated calcium phosphate, short stature, bone pain, fractures, delayed walking, and potentially premature loss of teeth. When you lose the teeth with their whole root, so people will tell you that when you ask the history. And you may also see radiographic evidence of hypophosphatasia, which you can see in this X-ray, where you get you get tongues of radiolucency, like you can see on the right where the arrow is. So this is another condition which very recently there is a treatment for. So hypophosphatasia is caused by a mutation in TNS-ALP, so you get deficient alkaline phosphatase activity and substrate accumulation. And we now have the option to treat these young people with aspartase alpha. And we've been using it in the UK for several years. So it's enzyme replacement therapy. And it's really, really amazing enzyme replacement therapy. So you can see on the left a child at baseline, they've got really quite widespread radiographic abnormalities. And as soon as 6 months later, so with your middle X-ray, there's significant healing of those bones. And by the right, far right, which is almost a year after treatment has onset, it's very difficult to identify any abnormalities in the bones. So improvement in less bowing, improved shaping, and none of the abnormalities you can see in the first X-ray. I looked after a young child who was ventilated at birth, so I had an X-ray where actually you couldn't see any of their ribs at baseline. And similar to in this case, you can see ribs appearing in front of you, and the child was able to come off the ventilator 6 months later. So we know that there's huge improvements in survival. So 95% survival at age 1 year, whereas before it was 42%. And in older children, 84% against 27% at 5 years. So it's incredible for these young people. And from a functional point of view, the improvements in functional are also exceptional. So I think that's the end of my slides. Thank you very much for your attention.
Thank you very much, Dr. Emma, for the excellent presentation. Till Dr. Kalpana and Dr. Joshi, they are preparing the questions. We will have a very short video, 2 minutes. Then I will request Dr. Asma, Dr. Nandu to join us for a question and answer in the panel.
They have their presentations.
Yeah, Dr. Saurabh, due to the short
Dr. Nandu.
we will not have any video presentation.
Okay,
Instead,
thank you very much. Then I would like to request Dr. Kalpana and Dr. Joshi to start the question and answer session. I would like to request Dr. Emma,
Doctor, they have to do their presentations, Dr. Asma and Dr. Nandu.
Yes, they will do. In the panel, they will start presentation. So Dr. Asma will start and followed by Dr. Nandu, and then question and answer will be there. So Dr. Asma, please. Yes, please, you start, Dr. Asma. Welcome.
So, hello, everybody. Okay, so can you see my slides?
Not
No.
yet.
Can you see my slides?
No, doctor.
Okay, hold on a second. Let me just do the share. Just 1 second. Okay, I just need to minimize this one.
We can see it now.
Yeah, I just need to. Okay, is that clear now?
Yes.
Okay, so I'll start my presentation now. This is, so here we have one lovely 14-year-old Emirati girl who presented actually for evaluation of short stature. She's always been petite in size with no significant complaints. Her review of system was non-significant. She's not on any medication, and her past medical and surgical history is non-significant as well. The girl was born at term with a good birth weight, around 4 kg, with an eventful pregnancy, and her development is being appropriate for age. Regarding her family history, she's the second child out of 3 siblings. The parents are non-consanguineous. The dad is healthy. He's a bit short. He's around 160 centimeter and had delayed puberty. Mom is healthy, and she's 155 centimeter tall. She had delayed menarche. She had her menarche somewhere between the age of 15 or 15 and a half years. No significant family history apart. There are some members from the dad side, mainly, who are short. Okay. So on examination here, we have a young lady, lovely. She's, her weight is 28 kilos, so it's her Z score is -3.9. Her height is 136.8 centimeter, which is the Z score of -3.5. And her BMI is at Z score of -2. Systemic examination showed generally she had some high arched palate with borderline low set ears, very few freckles on the face, and 2 small non-significant cafe au lait spots. Her chest was clear, cardiovascular, there was a soft systolic murmur, grade 2/6. Abdomen was clear. Tanner staging, she had normal external female genitalia, and she was prepubertal with Tanner staging of P1 and B1. Examination of the CNS and musculoskeletal system was non-significant. So, and you can see here, this is her growth chart. I don't know if my cursor is clear. So she's really quite short for her age and for her mid-parenteral height as well. So in normal cases, and this is, you can see, this is her, sorry. So this is her, the curve for her weight, and this is her BMI. So what do we have here? So we have a 14-year-old girl with a short stature. She's underweight as well, with failure to thrive, delayed puberty because she's 14+-year-old, and she her Tanner stage is P1, B1. She have no secondary sexual characteristic. She has soft systolic murmur on exam, and maybe very subtle dysmorphic features. So in normal situation, I will ask you what you will do next, but for short sake of time, I'll start with investigations. So we started investigating this girl. So her initial investigation, her blood count, renal function tests were normal. Her karyotype was normal. Her LH, FSH, and estradiol were at a prepubertal level, and her prolactin level was normal. Her thyroid function test showed a bit high TSH, repeated 6 weeks apart, and low normal T4. And at that point, she was started on thyroxine treatment. Further investigation, she underwent growth hormone stimulation test with glucagon, and she peaked very nicely. Her peak growth hormone at 120 minutes was 35.4 nanogram per ml. She had even a good cortisol response of 1,494 nanomole at 180 minutes. She had also an LHRH test because now she And her, as I mentioned earlier, her prepubertal level of LH and FSH were prepubertal, but at 30 minutes she peaked. Her LH was 8.6 and FSH of 11.6. Further radiological examinations show her bone age was mildly delayed. Her ultrasound pelvis showed a very pubertal size of small uterus and ovaries. Her MRI SELA was normal. And because of her cardiac murmur, she had an ECG and echo. An ECG showed a right axis deviation with borderline LVH. And her echo showed hypertrophic cardiomyopathy with asymmetric left ventricular hypertrophy, mild left ventricular outflow tract obstruction, and mild aortic valve insufficiency. Okay. So based on that, we went for further genetic testing, and the genetic testing, she had a whole exome sequencing, and the whole exome sequencing was positive, and it showed pathogenic heterozygous mutation at the PTPN11 gene, which encodes for Noonan syndrome. Further investigation for the family member, it showed also the dad was a carrier, plus her two sisters, where the mom was normal. So now here we have, now by the time I'm presenting this, is a 17-and-a-half-year-old girl who's in case of Noonan syndrome with a PTNP11 gene mutation with the following problem. She had a short stature, so she was started on growth hormone treatment at the age of 14 years. For the first 6 months, the treatment was interrupted because when the left ventricular hypertrophy was discovered, just in case for evaluation and to see if there is any effect of the growth hormone on this hypertrophy, so the treatment was interrupted, but then she continued in her growth hormone treatment. She also had a delayed puberty, so she had a good response in the normal LHRH test. And she was started at the age of 14 and 10 months with the estrogen replacement therapy, which was increased gradually every 6 months. Around 1.5 years later, pelvic ultrasound was repeated, and it shows an endometrial thickness of 4.7 millimeter. But she didn't have any breakthrough bleeding, so a progesterone withdrawal test was done, and she had a good withdrawal bleeding. And she was almost reaching her 18th birthday at the time she had her menarche, and the estrogen replacement was discontinued. She also had hypothyroidism, as her TSH was high in 2 occasions with low normal T4. So started on thyroxine, and she maintained good thyroid function test on just 50 microgram of thyroxine daily. She also had a cardiac murmur with mild left ventricular outflow tract obstruction and right axis deviation, for which she was being followed by the cardiology, and she's on atenolol. I want to show you her, this is when she presented to us. So this was her growth, and this is what she ended with. Okay, and this is if we take a normal female CDC growth chart. So she's between around the 10th to 25th percentile for a normal female. But if you put her in the Noonan curve, you could see, so this is in the Noonan curve, you could see how beautifully she did. She almost reaching around the 90th percentile when she plotted on the Noonan curve. So basically that was my case presentation, which has a patient with a short stature and a delayed puberty at the same time.
Thank you very much, Dr. Asma, for the nice presentation and very brief. Now I'd like to request Dr. Nandu also to present, and then the panel will start with Dr. Kalpana and Dr. Joshi. Dr. Nandu, please. Over to Dr. Nandu. Dr. Nandu, yeah, please.
I need Dr. Asma to stop sharing so I can share.
Yeah, I do.
Did already. You can start sharing, Doctor.
Okay, I'm good. So I'm going to tell you a salutary tale of a disastrous diagnosis. Samantha came to see me when I worked at the Norfolk and Norwich Hospital back in May 2004, this was, with short stature and secondary amenorrhea. She was a previously healthy girl, born at term, normal birth weight, and no real issues. She was the only child of this family, living with her mom. They had moved down from Glasgow to Norwich following their parents' divorce. And she'd had menarche just after the age of 11, but at the point when I saw her, she'd had no menses in 7 months. However, prior to her period stopping, the periods have been very heavy, prolonged, and irregular, with dysmenorrhea, flooding, and clots. And actually, when she got amenorrhea, she was initially relieved, but mother was concerned and sought a referral to gynecology, who didn't feel there was anything untoward. And she had a withdrawal bleed with norethisterone, so advised coming to see an endocrinologist to check out the hormones. And also because the gynecologist felt the periods would likely restart, and therefore that they may need managing from a hormonal point of view. And most gynecologists aren't happy treating 13-year-olds with an oral contraceptive pill. So here is her growth chart, and you can see she is very short. And actually her parents were very tall, so she should really be a 98th centile girl. So she's short and short for her parents. And you can see she has a markedly advanced bone age, showing epiphyseal fusion. So unfortunately, she was at the end of growth, 142 centimeters. That's terribly short. And on examination, she had a high arched palate, curved hyperconvex nails, and numerous small moles. Looking back through her notes, I found that she'd been treated conservatively for glue ear when she was 3 years old. So the thought in my mind was that could she have Turner's syndrome, which is obviously a rather unusual presentation of Turner's, but nevertheless, that's what I was thinking of. Her FSH was perhaps a little bit high, and therefore, in keeping with that potential diagnosis, but LH was also reasonable. It wasn't grossly out of balance. Estradiol was good, thyroid function normal, and pelvic ultrasound was normal. She did have a duplex right kidney, but otherwise nothing exciting. However, her karyotype came back as 45X on 30 cells examined. Incidentally, since I've come to UAE, I've been deeply shocked when I've seen karyotypes on 5 cells. This is completely hopeless. Looking at 5 cells is atrocious and not fit for purpose for a karyotype. Now, this is where it started to become a disastrous diagnosis. Unfortunately, Mother and Samantha were just completely overwhelmed by this diagnosis. And in particular, the future infertility was very difficult for Mother and for daughter. And Mother really, said, this isn't true, it can't be true. We tried to reassure her that the testing had confirmed it. And I advised, as indeed her gynecologist had, that periods would probably return, but she would be likely to have menorrhagia and subsequently the development of menopausal symptoms, in the same way that older women may have severe menorrhagia preceding the menopause. So her periods did resume, and they were very heavy and unpredictable. So we started her on an oral contraceptive pill to control the menorrhagia. Low estrogen 20 is a common pill in the UK, but she reported breakthrough bleeding, so we increased the dose. And then later we switched her to a triphasic preparation with a non-steroidal and tranexamic acid, but still she reported intractable symptoms. However, I spoke to her GP actually at a meeting I was at, we were talking about her, and he told me that she wasn't actually collecting her medication, so that might have something to do with the lack of effectiveness of the treatment. I next saw her the following August, she was extremely tearful and depressed. And her mother, now age 47, had a new partner and was pregnant. Subsequently, Samantha defaulted again from follow-up for another year. And she was just absolutely convinced, she told me, that she didn't have Turner syndrome. It couldn't be true. She said her periods were regular. She wasn't going to take any medication. There was no need to come and see me anymore. And that was that. So this is a very challenging and difficult thing. I thought I was awfully clever making this diagnosis, but actually this diagnosis broke this family apart, causing mother to respond to this infertility diagnosis, which was the problem that mother had with it, by getting pregnant, essentially, with a new partner to replace the future grandchildren. And naturally enough, Samantha reacted by rejecting the diagnosis and refusing further follow-up. So this was a very sad outcome. And actually, it's especially sad because the problem with Turner syndrome is that girls do need ongoing management and care in adult life, which is terribly important. There's no reason why she couldn't have children, actually, even if it was by egg donation. I know that's not done here in UAE, but in the UK, that's fairly normal practice for girls with Turner syndrome. So that's all I have to tell you about my disastrous diagnosis.
Thank you very much, Dr. Nandu, for a nice presentation of this case. Now I would like to request our distinguished panelists, Dr. Ima, Dr. Asma, Dr. Nandu, to join. Dr. Kalpana, Dr. Joshi, please take over and start the question and answer session.
Yeah, sure. Thank you to Dr. Emma and Dr. Asma, Dr. Nandu. We've had very interesting cases here today. So I would like to start the panel by asking a question to Dr. Emma. This question is from Dr. Amir Ahmad from Pakistan. He would like to know what is the risk of fracture in DMD when patient is on 10 days steroids on and 20 days off. So, Dr. Emma.
I think that's difficult to quantify. It depends on the starting point. Presumably this is a child with Duchenne's, is that the suggestion?
Yes.
So any child with Duchenne's is already at very significant risk of fracture. The risk is slightly lower if you're on a 10 days off and 10 days on regime, but in those young people, I would still be monitoring them on an annual basis to look for fractures proactively. Because if you look proactively and treat when you first see a vertebral fracture, hopefully you will prevent the vertebral fracture cascade that we saw.
Yes. So, Dr. Emma.
I have a question on the same topic. Can I just add it now?
Sure.
There's a question about the steroids. Is the incidence same with the newer steroids also, like deflazacort and prednisolone? Both are having sex?
Yeah, I haven't seen data that's compared them, but I've got quite a few patients that still have very significant vertebral fractures on deflazacort.
Yeah, Dr.
No, I was just going to ask Dr. Emma that, yes, Duchenne's is one case that you presented, but are there other neurological conditions that you get involved in monitoring their bone health? And if yes, what cases would those be?
So I think that's a really good point. There aren't any other cohorts that I tend to see proactively, but I am involved with a few children with SMA, for example, who obviously have very significant impact on their bone health, and children who've got immobility, for example, because of cerebral palsy. But in those children, I tend to get involved if they have long bone fractures. So it's a slightly different, it's less proactive. So if I would tend to be referred by my orthopedic or other colleagues, children who are having clinically significant long bone fractures for consideration of treatment.
Okay. Yes. Joshi?
Yeah, there is a question about the role of vitamin D and calcium in the prevention of fractures in both DMD and osteogenesis imperfecta. Is it going to help to give the higher dose?
So again, a really good question. So I have my approach to vitamin D and calcium is the same in everybody. So all of us need to have a normal vitamin D, ideally between 50 and 100 to have optimal bone health. And all of us need to have a normal calcium. So generally, I don't measure vitamin D unless you have a bone problem. I just tell, and this is any pediatric patient I see, I would always talk about vitamin D, but I only measure it in my bone patients. So I suppose the difference in bone patients is that I will proactively chase it, and I will encourage people to improve their compliance. Because in the UK, and I don't know what it's like with you, but in the UK, there is not enough sunlight to make vitamin D between October and May. So all of us need to be taking it for those 6 months. So there's, you know, I don't.
Sun in Dubai, no one gets out of it.
Yeah, so I mean, you know, for a different reason. And calcium, I use, there was a very nice paper in Archives by Raja Padadella, who he created a sort of it's a 5-item food questionnaire that you can use to ask people their calcium intake. So it's how much bread do you have, milk, yogurt, cheese, and vegetables. And you use those 5 items to calculate calcium intake. And so I do that universally in my calcium clinics, or if I see someone who's not, you know, that comes across they're not eating very well. And if that's a problem, I'll try and address it.
So there's another question from Dr. Saad, who would like to know what's the proper time to do BMD study in a child with nephrotic syndrome who's on long-term prednisolone therapy.
Yeah, so that comes back to the point about recovery. So a lot of children that we look after in general pediatrics will have the potential to recover. And so I don't look after nephrotic syndromes that commonly, but the majority of them you would only expect to be on steroids, say, for 6-12 months. But if you've got someone who's on them for longer than that, I wouldn't necessarily be measuring bone density actually, because that's not particularly helpful. But what I would start doing is lateral vertebral morphometry, because if you have a bone density that's less than 2, it just creates anxiety, but it's not going to change my management. Whereas if I've got a vertebral fracture, it's going to change my management. And at that point, if I have a vertebral fracture, I will perform bone density so that I can monitor my treatment.
So on the same topic of bone mineral density, you spoke about DEXA and its limitations. I believe different manufacturers have different ranges for children. So it depends on the equipment that you're using. I'm talking about the results. And there was, you mentioned about the slide that you showed with 2 cubes and having the bone density being the same. So in relation to that, there have been certain suggestions, like you could do a quantitative CT or a quantitative ultrasound. Any comment on that?
So I think quantitative CT is great if you've got it and you've got the normative data. I don't have access to that locally. So I don't have a lot of experience in using it, but definitely the big children's bone centers use that as an adjunct, but it's not their main. So if I think of, Birmingham Children's Hospital, Sheffield, the kind of really big bone centers in the UK, that's not their first line. And so DEXA, the report you get shouldn't be different. So if you use a scanner you need to pick a scanner for children which has normative data available for children throughout childhood. And then you need to, so you need to check that the report you're getting has got that data incorporated in it to give you the results. And then your result is comparable between different scanners. Although ideally, if you're looking at the same individual, you will scan them on the same scanner repeatedly, because just like other equipment, there is variation. But it's, yeah, I don't use scanners that haven't got the pediatric data available.
Sure. But as you mentioned, if I got you correctly, that the data is available for more than 5 years of age.
Yes.
Yeah. So like, for example, in your first case, by 5 years, the child had vertebral fractures. So how would we pick up this child in, a younger age group?
Well, so that child, if I'd seen them earlier, I would probably have done the genetics. So we've moved leaps and bounds, haven't we, in the last 5 years? So we can now. Yeah, I mean, there was lots of hints, wasn't there? And also, for osteogenesis imperfecta, it only matters to have the diagnosis really once you're thinking about treatment. So the optimal treatment for that young person would be they would have been referred when they had one vertebral fracture. Yes, what was not picked up there was that one vertebral fracture is enough. That's the diagnosis for osteoporosis. So DEXAs are not really part of diagnosis. And I think there's too much focus on them in children in a way, and maybe a lack of understanding of their value in children. They just give you part of the picture. And if I'm starting bisphosphonates, I do use them to decide when I'm going to reduce treatment, increase frequency between treatments. But they're never part of when I start treatments.
Sure. So I would also like to ask Dr. Nandu and Dr. Asma to give their inputs on this. Which other cases you use DEXA really, and how effective do you find it in?
I'll start if I may. I mean,
Yes,
I found in Dubai anyway that it's very hard to get anything approaching a sensible pediatric DEXA report. I mean, I've literally had a report with a number on it as the sole piece of information, which is completely hopeless. Now, I understand from Dr. Sarah Etisham at Mediclinic City Hospital that they have a new DEXA scanner with full pediatric reference data, and they will be providing proper reports, which would be fantastic. It'd be such a great thing to have a resource like that. But I agree with Emma that really it has no role in diagnosis. It's for guiding therapy. So you make the diagnosis of osteoporosis by other means than DEXA. DEXA is just a good baseline measurement for then you can monitor the child and see how they're responding to therapy.
Sure.
For me, in my current center where I'm working, we don't also have any data for the norm data DEXA scan for the children. But in my previous hospital, we did have, and most of the time it was difficult to get, the proper Z-score for these children. But what I used to do is that at least if you do them annual DEXA and just see the trajectory, how they are improving at least. So plus their vertebral X-ray. So put these two things together, at least to help you to monitor how the progress is going on. It's very difficult when you don't have the normal standard for the children. So you have to find your other ways to do it.
Sure.
There is a question on epilepsy and anti-epileptic drugs and bone health. Epilepsy, anti-epileptic drugs, and bone health. Do you need to monitor or do anything extra?
Nominate Emma.
I mean, that's quite a wide question, isn't it? It says query epilepsy and bone health routine. So I don't monitor it as a routine. Some of the bone drugs, I would just say I've seen children who've been referred to me because they can do funny things to your bone X-rays. That would be the only thing that I've picked up, that doesn't need anything doing about it, and it gets better when you stop the drugs.
So there are two questions from Dr. Annes regarding your last case, hypophosphatasia. One is, can you pick it up prenatally? And the second being, when do you actually suspect it? As there is like, I think he wants to know how early can you diagnose, as there is curative treatment.
So I sort of skipped those slides, didn't I? Sorry. There are different forms of HPP. It can be recessive or dominant. The more, just like other things in pediatrics, the recessive forms tend to present earlier and be more severe, and they would obviously tend to therefore not be familial. So less that you could diagnose it antelatally, but it's less likely. So you'll see abnormalities antenatally on ultrasound, but it tends to be a postnatal diagnosis, especially in the UK where we don't have very many antenatal ultrasounds. So we only have scans at 12 and 24 weeks routinely. However, if you have a dominant form of HPP, it tends to be familial. And a bit like OI, most of my patients with OI know they're going to have a baby that's got a 50% chance of OI, and I tend to talk to them before they're born. So yes, that could be picked up antenatally. And how early it presents depends whether you've got a perinatal, which used to be lethal form, and that's really obvious. Those babies, when you x-ray them, don't really have any bones present and tend to require respiratory support. And when you do their bone biochemistry, they have a really low ALP and other abnormalities. And if you've got the childhood, then there's an infancy form, which again is kind of more severe than the childhood form. So it depends what type you've got, what age it tends to present.
I would just add that often labs have a reference range for alkaline phosphatase in children that'll say, you know, less than 350 or something useless like that. Whereas you should never, ever see an alkaline phosphatase less than, I don't know, 100 in a healthy child if they're actually growing. So that's, you know, I mean, even 100 would be very low, to be honest, but, you know, unless you're doing something to them, like giving them, you know, zoledronic acid, there's no reason why anyone who's growing would have an alk phos less than 100. So I think you have to be conscious that alk phos in double digits is abnormal in a growing child.
Right. So on the same issue, just asking a few more questions to you about the enzyme therapy, Dr. Emma. Is it a very expensive treatment? How often do the children require it? How is it administered, and for how long?
Yes, it is very expensive, but don't ask me how much it costs. It's so expensive that in the UK, you can only have it prescribed in 3 centres. So it's limited by the NHS. So my patients I see locally, but they also have to go to Birmingham, which is obviously quite a trek. So yeah, it is very expensive. It's given subcutaneously by the family, and I can't remember how often it is, if it's weekly or twice weekly. Do you remember, Nandu?
Twice weekly, I think.
Twice weekly, yeah. And it's for life, really. I mean, if you don't want the symptoms to come back. So yeah, its half-life isn't long enough to just stop it.
They're severely symptomatic without treatment, so lots of pain. Pain is terrible.
Yeah.
Okay, and as you've been using it for quite a few years, you mentioned, the response obviously is good. What is they lead a normal life then?
Yeah, it depends again on the severity. So the little chap I described who was so severe that he literally had no bones on his x-ray and was ventilated still for the first year of his life. I mean, the difference for him is, well, he has survived and he's now, you know, significantly better than he would have been. But the children who have the infant or childhood, they just don't have pain anymore. They're normal compared to where they were before. It's not 100% in everyone, but if you go to talks on people that developed it, they'll show you a child that's in a wheelchair that gets up and walks.
Sure. Dr. Asma, any local experience with this therapy?
I didn't have any patients with on enzyme therapy, but we do have, I mean, in the country, but personally myself, I don't have a patient.
Maybe Dr. Nandu has?
No, I don't, sadly. I did in Norwich, but now Emma has inherited any patients I had.
I have seen one case when I was working in Oman. Hypophosphatasia, it was associated with hydrocephalus. Have you seen any kind of association?
Yeah, my very first patient had hydrocephalus associated, and actually the alkaline phosphatase, they actually presented with craniosynostosis. They were about 6 or 7 weeks old, very unwell, and the alkaline phosphatase was 25. So the diagnosis was clear right away. Actually, the radiologist suggested the diagnosis as well, independently of me. So it was a very clear-cut case. But yeah, craniosynostosis is a particular issue in some of the infant forms.
To my best knowledge, that there are only, I think, 2 patients in the country who are getting treated.
Okay.
Yeah, but in a different center.
Okay.
There is a question on achondroplasia. With the current therapy, like you said about CNP, will it increase the disproportionate growth of the bones like it happened with growth hormone when they started using growth hormone in the beginning for achondroplasia? Does newer therapy also do the same thing, or it corrects only the abnormality?
So I don't think we've got enough data to answer that. It's the answer at the moment.
There is some data showing that it improves body proportions. So, I mean, I read about one child who could, go to the toilet unaided because her arms were longer and she could actually reach, which, is obviously a big thing for a child growing up. So I think, the initial indications are that it's very promising. And I guess earlier treatment will be better. So the trial for infants is underway, isn't it?
Yeah, I think that's the really important. What happens if you give it at birth?
So, Dr. Asma, there's a comment about your case that you presented saying that most of the cases of Noonan that we see are in males. Yours case happened to be a girl. And the other question is that your patient was 14 years with mild delay in bone age. What was her potential for growth? As in 14 years with mild delay in bone age, growth plates remained open for how much time?
Yeah, so that's an excellent question. So if you remember her growth chart, the patient was really, her Z-score was minus 3.5 standard deviation, I believe, when she started treatment. And with her positive genetic testing, I think she deserved that to give her a trial of growth hormone. And when she started on growth hormone, she really responded really very well. So as long as she was responding well, the growth hormone treatment was continued. And I know that at the beginning, the bone age was not that delayed, but she responded really well on treatment. So it was continued till her growth was completed.
Right.
And what was the other question? Sorry, what was the other question?
No, it was a comment that this happened to be a girl, though classically we think of Noonan more in boys.
Yes. That's why she was a bit tricky. I mean, even when she presented, she's such a lovely girl that even the dysmorphic features which she had were really very subtle that I think you won't pick it up, very just insignificant freckles, borderline low-set air, some high arch palate, and that's it. So it's mainly, let's say, even were detected by when she was referred to the geneticists, when we referred her for the geneticists for the whole exome sequencing. So maybe these subtle were picked up even more, but she didn't have, and she did 14 years without any problem.
I think growth in girls is often overlooked, to be honest. I think that's why it's thought of as being something that affects boys, and Noonan's affects girls and boys equally. So
Yes, exactly.
yeah,
And you know, like the other thing is, if you remember, I told you that there is multiple family member from the paternal side who were short, so they were taking it as a something, like it's a familial short state.
Thing.
And so I look at this case that it's not like reaching from top to diagnosis. I think we reached the diagnosis and then we meshed. It's the vice versa.
And on genetic testing, even the father was found to have.
Yes. So the father is he's a bit short for a man. He's 160 centimeter, and he himself had delayed puberty. So if you take the history itself for a girl presenting at this age, so it goes very much with constitutional delay of growth and puberty. With a very, and she had actually mom who's normal. She also had delayed puberty. So the very strong family history of delayed puberty, short stature. So having her initial karyotype normal, everything, you could have stopped at that point. But putting the abnormal cardiac finding, because if you remember, I mentioned that she had left ventricular hypertrophy, which is asymmetrical, and she had the right axis deviation, which doesn't go together. And putting these together is a more pathognomonic of Noonan syndrome. So that we opted to investigate her further. And there we found that her genetic testing was positive. And now her... Yes. Well, the father, no, but her sister is on treatment now.
Okay. But the father didn't have any dysmorphic features or congenital heart?
No.
There's supposed to be increased risk of malignancy, nothing like that?
Well, so far, no.
So far, no.
They do get more normal appearing as they get older, with particularly the PTPN11, but it's not universally
That's
true.
good news.
Mm-hmm.
So, but it equally makes it harder to diagnose. So,
right.
There is a question on growth hormone.
Just a minute, doctor, about that itself. In the past, it was said that Noonan's is kind of Turner with the normal genetics, right? And now it's with your whole exome sequencing that you pick up the mutation. Otherwise, on
even
the whole,
then, you're
only getting
only 80% with whole exome. There's still 20%. We have no idea what's causing it. So PTPN11 is by far the largest cohort, but there's so many genes that cause Noonan's and Noonan-like syndromes, and there's overlap syndromes as well with neurofibromatosis, for example, that it's a very complex area, and you have to really look very carefully at all of the different genotypes. So if you have someone, say with Costello syndrome, which is part of the spectrum, I would be very wary of giving a child with Costello's growth hormone because of the huge malignant potential. PTPN11, it's acute myeloid leukemia. There doesn't seem to be much risk from growth hormone with that, but it's a difficult call when you have a potentially malignant predisposition with many of the genotypes.
I think now with current situation, I think most of the normal population will also not have normal genomes. Some variations will always be there. There is a question about the growth hormone. What is the right age to start growth hormone in Noonan syndrome, and for that matter, even Turner syndrome, and how long?
Growth hormone for whom? Like at what age?
No, Noonan syndrome, yeah, for growth failure.
Oh, for growth failure. Okay. So, this girl presented very late, but I think if patients presented earlier, it depends on their growth. If there is any once they're not growing well or they're not catching up with their growth, we started growth hormone treatment. But I don't think it's before the age of 2 years, not before that.
And if we use the model of Turner syndrome as a which is not the same, obviously, but in general, the earlier you start treatment, the better the growth outcome. I mean, you did incredibly well with that girl, actually. So if you're diagnosing a child with short stature at the age of 6, due to Noonan's, then provided the genotype isn't inimical to growth hormone treatment, then it would be not unreasonable to start it then.
So if you get a child who comes to you for short stature, is genetic testing a regular part of your workup?
For females, you must do the karyotype, at least the karyotype. And then as Dr. Nandu said, the problem is the number of cells is being tested. So you need at least 30 cells. And that's one of the problem that in many labs here, they go with 5 to 20 cells. With that, you can miss, a number of turners. For the female, it's a part of the short stature. You have to do for them the karyotype, when you investigate them. For the boys, it depends in the, if there is severe short stature, if there is any dysmorphic feature, or you have the gut feeling if there's something syndromic is going on. But not.
Yeah, definitely. If you have dysmorphic features, probably you do it. But if not,
no. If not, usually for the males, I usually don't do. I mean, unless there is something abnormal in their exam or history.
And when you say about the number of cells being examined, say, for example, in Turner's, is it because we are going to miss the mosaicism cases or?
Yeah.
Because otherwise it should pick up, right?
Exactly. Yeah. Yeah. Going to miss also, not to miss the mosaic one.
Okay.
So if you examine 25 cells, that gives you a 98% confidence of detecting mosaicism in Turner's. So, you want to be confident you're not missing an important diagnosis. And if you only examine 5 cells, that's a waste of time. I mean, that's criminal. That's taking money under false pretenses, in my opinion. So,
do these cases behave differently from the classical Turners in terms of their, clinical features? We know they are milder variants, isn't it, phenotypically, but otherwise?
They may be milder, but it's not always true, actually, because it depends, because the mosaicism is not always uniformly distributed throughout all tissues. So I don't think you can generalize about that point, actually. I mean, I've seen, girls with 45. I mean, if you think of Samantha that I presented, I mean, she looked really very normal, very subtle things that I was noticing that gave me the clues to possible Turner syndrome. And, to all intents and purposes, she looked completely normal. Whereas on the other hand, and she was 45XO. And yet on the other hand, I've seen girls with minor mosaicism who really obviously floridly Turner syndrome. So I don't think you can generalize about how you will appear.
Right. And rarely haven't they reported pregnancies in Turner's?
Yes, that can happen.
There are a few questions about sickle cell disease and bone health and any medications for that. Biphosphonates for sickle cell disease. Dr. Emma, it's for you.
Well, I haven't, we don't have many patients with sickle cell in Norwich. So I don't have a great expertise in that. In terms of, I think the question asked which sort of bisphosphonates.
Yeah.
In the UK, we still tend to use either permidronate or zoledronic acid. And it's really interesting because it depends where you've trained in the country and who you've trained with, what your preference is. There is much more evidence about the safety and the dose response regarding permidronate still, because that was the first bisphosphonate that was available. And there's much, much less data available on zoledronic acid. And actually the dose we use is very high. But personally, I still do tend to use zoledronic acid if a child with sickle cell did come to me with fractures and I was going to make a decision, I do tend to use zoledronic acid purely because it's 1 day, half an hour. But I think that's, actually it's very variable. So I don't know if any of the other panelists have actually got experience of using it in young people with sickle cell.
Not with sickle cell. But I just think it's much kinder to have one infusion every 6 months
Yeah.
for half an hour than, 3 infusions on consecutive days over, every 3 months, at least until, the bone health has improved. So I think that's very tough treatment.
So I think the reason I would use pamidronate is kids with SMA seem to be at higher risk of complications, and there seems to be less complications with pamidronate and lower doses. So I think it's if it's someone you're really worried about that they're going to have a really bad first phase reaction, then I'd be more tempted to use pamidronate. But otherwise, I completely agree. The majority of my patients are on zoledronic acid.
My experience about in these patients with OI and those who are on biphosphonate treatment, they are mostly on zoledronic acid.
May I ask one question, Dr. Kalpana?
Yes,
These
doctor.
cases presented by Dr. Emma, Dr. Asman, Dr. Nandu, late presentation, late diagnosis, and Dr. Emma also in one of the criteria put at 10 years if these changes are there. What future holds for us? I mean, now they are going for intrauterine diagnosis. What do you think, which one of these diseases can be diagnosed in intrauterine? I mean, the 2 years, 14 years, 10 years, 17 years, are too late. I mean, what do you think future will tell us about the early diagnosis?
Well, we better have a geneticist in this panel who can answer these questions. I'm sure that most of these which we are talking about could be diagnosed antenatally, but
I attended a global, I think it was a global meeting of experts in achondroplasia recently, before COVID stopped us doing things like that. And there was people from 8 different countries, all who run kind of multidisciplinary achondroplasia clinics. And one of the things that was really interesting was in the UK, because partly as what I've said, our schedule of antenatal ultrasounds is not very frequent. So most of the clinical signs of achondroplasia, the growth phenotype actually develops after your 24-week scan, and not all of it, but you're more likely to miss it if you don't have a later scan. So actually your scanning comes into that. But if in the countries where they had a much more comprehensive antenatal scan system, they had a much higher pickup rate of achondroplasia antenatally. But then some countries weren't doing genetic tests beforehand. They were still doing doing an antenatal CT scan. That's what France does. Whereas in the UK, and some places are still doing CVS, so chorionic villus sampling, which obviously has then a 1% risk of miscarriage. So in the UK, we do diagnosis antelatally if it's thought about by taking peripheral blood and looking for fetal cells, and that's actually has a really good pickup rate. And it's a great question, and that's what I think about. What if can we use these treatments antenatally? Possibly, but I think we're not quite there yet. But that's what needs to happen, because I know that if you're going to have spinal cord stenosis at birth, then yes, we need to be doing something about that at 24 weeks.
So I think the dropping price of even whole genome sequencing is really remarkable. I mean, commercially available as opposed to clinically available testing for whole genome. I mean, I get advertisements from sequencing.com. Your whole genome sequenced for $399. And you think, crikey, that is incredible what has happened in the genetic world. And it may well be that, in the future, there will be comprehensive genetic testing. And when a diagnosis is questioned, you go and interrogate the genetic information that's there. That may well be one vision of the future, but that's probably another 20 years away, I guess. But it's certainly, I think, genetic diagnosis is the way to get that early diagnosis. Relying on doctors, we keep missing it, unfortunately.
Moving on, there's a practical question from Dr. Bushra. She would like to know whether you use ionized calcium or total calcium for initial checkup and follow-up for these cases.
So if I'm like in the HPV, if I'm seeing someone in clinic, I tend to get a total calcium back. But it depends where you are. I mean, I recently had a child where we picked it up on a bedside gas, and that's an ionized calcium. So it doesn't really matter which one is your first point of call if you've got someone with an abnormal calcium. And, if you're monitoring it, again, it doesn't matter hugely unless you think that there's something in that child that's going to make your ionized calcium very abnormal.
Right. Dr. Khalid would like to ask Dr. Emma that your fourth case of X-linked hypophosphatasia, usually upper limb and axial skeleton does not show features in these cases, but only lower limbs and teeth. But in your case, both upper and lower limbs were involved. Is it possible to have both of them involved?
Yeah.
Well, I think so. An X-linked hypophosphatemic rickets is not. It's
not the
different,
same as.
Yeah. So it's,
okay.
they're different. Yeah, but yeah, in XLH, which is another interesting condition, the lower limbs are more affected usually.
Right.
Oh, sorry.
It's a question
Good
to.
question. Thank you.
Question to Dr. Nandu. This girl, I think the case you presented had advanced bone age and high FSH-LH hormones. Was that precocious puberty or pituitary abnormality?
So, so in this situation where you've got high gonadotrophins but a satisfactory level of estrogen, the implication is that the ovaries may be failing. The gonadotrophins are having to drive harder, and therefore you're starting to see a rise, particularly in the FSH relative to LH, because typically by sexual maturity, the LH is higher, not much higher ideally, but a little higher than the FSH. So that was the potential clue there. But really, you have to actually do the test that counts, which in that case was the karyotype.
Right. Dr. Hisham wants to ask Dr. Asma, how was the school performance of the child you presented? Did she have any learning difficulties or intellectual disabilities?
No, not at all. Not at all. Not at all. That was very surprising. She's a very bright student, and she's doing psychology actually now in the college.
Oh, that's great.
Yeah, her development is completely been normal. Gross and nothing. And that's why it was very easily to miss these cases.
It was a very good diagnosis.
Thank you.
There's a question about the growth hormone therapy. Can the pediatrician start it, or it has to be endocrinologist?
Well, endocrinologists are pediatrician, I think, at the beginning. We are all pediatrician before we become a pediatric endocrinologist. But I do believe that it should be given to the pediatric endocrinology. It's not only starting the treatment, it's monitoring also the side effects and the annual lab test, and it's much more than giving growth hormone itself.
Yeah.
I agree with Dr. Asma, and in the UK, NICE also says pediatric endocrinologists or other relevant specialists. So nephrologists do their own thing, don't they? They like to give growth hormone.
Okay.
There are a few questions for Dr. Sorab about the CME points.
Very good question. Very good. Excellent. So, an email will be sent to all those who have registered. There will be a questionnaire. Once they fill that one, CMEs will be sent to them. It may take few days, but it will be given to them. I think now it's 11:25. 5 minutes more, Dr. Kalpana, then, because
Sure.
distinguished, I mean, panelists are very tired. It's too late also. We were supposed to finish by 11. So it's so interesting and a lot of questions. 5 minutes more, please.
Sure. Dr. Hana Ali wants to know, probably to Dr. Nandu, whether you would advise DEXA for all patients with Turner's pre and post estrogen therapy.
I don't have a burning desire to do DEXA. I think this is a question that would be better to ask of Emma, to be honest. I don't particularly feel the need to do DEXA in girls with Turner's unless I have specific concerns about bone health. But please, Emma, get me out of the hole. Tell me what I should be doing.
I don't think it matters before you start it, but it is part of handover to our adult colleagues usually, because they're obviously at risk of osteoporosis as adults, potentially. So it's something that I do at that point, as opposed to relating, not a before and after, because it's not going to change anything again. What am I going to do if the child's got a bone mineral density of -2.5 before we start estrogen, which is probably not that unlikely, is it? Especially, it's not that unusual to present a bit late. And all that does is makes everyone anxious and gives them an extra diagnosis, which we're probably going to solve with estrogen and growth hormone.
Okay. And at what age do you hand over these cases? What is to adult colleagues?
So it depends on the individual patient and their needs, but between 16 and 18 would be what we would aim to do.
Right.
And I try not to hand over, try and do kind of a couple of appointments. It's more about getting to know, so I try and have more of a transition type things, so 2 or 3 appointments with the adult clinician, if we can.
Right. I think we have run through the... Yes, Doctor.
Dr. Asma, what do you do in government hospitals? Because they usually stop at 12 or 13, right?
Yeah. No. We have like most of them like a transition clinic, so between 16 and 18. So those with like a growth hormone deficiency or something, we retest them. I mean, around when the growth is completed, just to see if still have the growth hormone deficiency, because if so, then they will continue on growth hormone, but on the adult side with the adult doses. So it's usually between that age, 16 to 18 years. I just wanted to, have a small comment about the question you asked about the growth hormone treatment, if it's get treated by pediatrician. Unfortunately, in the beginning, we have seen so many cases were treated with growth hormone and without any proper indication. And, short stature, especially when it comes to boys, the parents will be really seeking advice, maybe more than in girls. And in many times we've been in endocrinologists and we sometimes feel a lot of pressure that, you need, like the parents are pushing to start growth hormone, but there is no clinical indication. You have to show them that, no, this is the child will grow, he's a constitutional, or this is a familial. So there is a lot of, counseling goes with short stature, especially when there is no indication for growth hormone treatment. I have seen cases, unfortunately, where growth hormone were given in cases where, shown to be pre-malignant, or the risk of malignancy is high. And that was like something almost, got to say that maybe an unethical treatment for these, just to, improve their growth, but you are putting them under risk of other. So you need to get also, updated about the indication of growth hormone treatment, which is I think it will be a bit difficult for a pediatrician himself to do it.
Sure. So I think across the board, all panelists agree that this is the area where we need the expertise and the experts to handle it. But coming a step backwards, at least I would like you to tell us in short about the diagnosis. A child comes to us with short stature. Okay, the least minimum after, of course, the clinical exam and all, investigations that you would advise. A lot of people do a lot of different investigations, random growth hormone assays. What is the value of that? So if you could comment on that.
No value. Unfortunately, there is no value for random growth hormone. I mean, never do a random growth hormone unless you think that the patient have a growth hormone excess, but otherwise there's no value. A growth hormone need to be tested by a stimulation test. So the basic
one exception would be an infant. So random growth hormone level in infancy is okay, but i.e. less than 1, but then it's better than IGF-1.
But for an infant, I will never start growth hormone unless he have really, I mean, hypopituitarism and there is an hypoglycemia.
Yeah,
So
I agree with you.
yeah, so I won't give him any growth hormone treatment. I mean, the only indication I give these children is if they have a hypoglycemia, because there is no much role of growth hormone at this age causing their growth. So the basic investigation you will do is a simple investigation, you know, like in many cases, sometimes we don't, I mean, the patient comes with shorter stature. I don't do anything, you know, I just give them a 6-month appointment just to see for the growth velocity. If I find everything is normal and there is nothing wrong with the child, you know, and the parents are concerned, and I'm very comfortable with my history and exam, and you know, the mid-parental height, I just sometimes, the maximum I could do maybe a bone age, or I give them assessment, you know, a 6-month follow-up to see the growth velocity. And if I didn't like the growth velocity, maybe I'll start the investigation at that time.
I think bone age is very helpful if you can get a reliable bone age. That's rather critical. So either you have to learn how to read them yourself, or use AI to read your bone ages.
So that's the only, I mean, the bone age and my brain MRI, these are the 2 things which I like to read them myself before looking at what the radiologist wrote. And
but any, I mean, okay, you have monitored the child and you are convinced that there is, you know, the velocity is not as good as you want it to be, then.
Yes, then. So the investigation, you go, you do them their full blood count, renal function test. I mean, especially looking for, you know, their CO2 to rule out if there is any acidosis, their thyroid function test, definitely. Celiac screening, because many of the celiac, which we have seen, they were picked up by endocrinologists before having any GI symptoms and being picked by gastroenterologist. The bone age and what's it, full thyroid, and then maybe the transaminases. These are the basic things which we go with plus the bone age and a karyotype in a female, and we go from there. And if there is something abnormal, you treat there. If not, then you go for growth hormone stimulation test. And
I do like to do a bone profile. So I like to do a phosphorus, calcium, outphos, because, you know, you do get these. I mean, my colleague, Dr. Mireille, had a case of hypophosphatemic rickets who literally walked into her clinic last week. So, you know, and that was the phosphate, that was the clue. So if you don't measure it, you don't find out. Plus, even though the child had a history of rickets, by the way.
I forgot the IGF-1 and IGF-BP3, just to add them to the initial investigation panel.
Okay. So yeah, so short stature, this is what the pediatrician will do, and then hand over to you, and you know, for your expert opinion and management. The other category we discussed today is probably menstrual issues. So precocious puberty is a totally different subset, but delayed menstruation. So if a girl, at what age should she get investigated, and what would be the least minimum investigations you would like us to do?
So for a female to say it's a delayed puberty, they should have no signs of any secondary sexual characteristic by the age of 13. So if they are prepubertal by that age, so they fit the diagnosis of delayed puberty. Or if there is no menarche after 3 years of breast development, you know. The minimum investigation I will do for them is at least like apart from just general health, the thyroid function test, LH and FSH, and their estrogen, prolactin level, and plus the renal function test and the liver function test. So I'll start from there, and then later on I'll go for the other, like the doing the pelvic scan, and but at least to start with that.
Okay. Joshi, do you have any other
But
questions?
for boys it's 14, so for the girls it's
So-
13 and boys is 14. So if there is no signs of any testicular development by the age of 14, it's that we can fit them that they are having delayed, or they fit the diagnosis of delayed puberty.
Kalpana, if you allow me, the rest of the question we will send to the email of our distinguished panelists, then we can send to the viewer. I would like to thank our distinguished panelists, Dr. Imma, Dr. Asma, Dr. Nandu, our moderators, Dr. Joshi, Dr. Kalpana, our viewers. Thank you very much. A large number from all over the world, they participated. And I would like to thank Mr. Tawfiq for sponsoring this, Fadi. Once again, thank you very much. This, if we sit, we're going to Sahar till morning, we'll sit and have. Thank you very much, Dr. Imma, Dr. Asma, Dr. Nandu. It was very interesting discussion. We learned many things. Inshallah, in future, we'll try to have more meetings like this. Thank you very much.
Yes, the cases were very interesting.
About CME also, email will be sent and they will get. Thank you very much.
Thank you, Dr. Emma. Thank you, Dr. Nandu, Dr. Asma.
Thank you for attending.
Lovely to see you, Emma.
You too. Bye.
Bye.
And Asma.
Good
And
night.
everyone else.
Bye, Nandu.
Bye-bye.
Okay, bye. Thank you, Doctor.